Right, welcome everyone to the February 29th, 2024 Board of Health meeting. I believe this may be the first ever meeting on February 29th. So, all right, we will call the meeting to order at 12:33, and we will go through and do roll call. Ann, will you assist with that?
Commissioner Josh Kearns.
Here.
Commissioner Amber Waldruff is expected. Commissioner Mary Cooney.
Present.
Councilmember Michael Cathcart.
Present.
Board Member Monica Blakowski-May.
Present.
Board Member Charlie Duranona. Board Member Patricia Keinholz.
Here.
We do have a quorum.
Okay, wonderful. Also, just some housekeeping items, just so everyone knows. All of our meeting information packets are in the binders in front of us. For those of you that are watching online, those are available on the SRHD website. If you'd like to follow along, it is on the website under the meetings tab. Also, just only 6 microphones on at a time, or else we do have a little bit of AV difficulties. We did receive 2 pieces of written comment from the public. Those are also in your binders as well. And would also like to welcome our new board members who are with us today, as stated earlier, Patricia Keinholz and Dr. Monica Blakowski-May. Welcome aboard. And thank you very much for being a part of this. So we'll move on to board reports. Chair reports. Had an executive committee meeting. We went over some of the information that is in our agenda packet today, but nothing too exciting for my report. Was there a budget and finance meeting this last month?
No, because we hadn't established the committees yet.
Okay. Wasn't sure if there was holdover from the previous makeup. All right. Well, then that will move us on down our agenda to the consent agenda. We do have several meeting minutes to approve. We have our January 22nd, January 25th special meeting, and our January 25th regular meeting. So, and then we also have the vouchers for January 1st through 31st. If there's anything that anybody would like to take separately, if not, or also open to corrections if anybody saw any corrections that need made, but if not, is there a motion to adopt the consent agenda, items 4A and B?
Mr. Chair, I'd like to make a motion to adopt items 4A and 4B from the consent agenda.
Second.
We have a motion and a second. Any discussion? Seeing none, all in favor say aye.
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 Aye. All right. Yep. Okay. Motion passes unanimously. All right. That moves us. I will check with legal counsel. Do we have any executive sessions queued up for today?
We do not for today.
Okay. Then we'll move on down to our action items. Item number 6, Board of Health Committee membership. So we have 3 committees that we have. This information is also in your packet. We have our Budget and Finance Committee. We have our Policy and Education Committee. And then we have our Executive Committee of the board. So I will just state one item about the Executive Committee of the board. Traditionally, that board is made up of the chair, the vice chair, and the past chair. But because all 3 of those people are county commissioners, that creates a quorum of the Board of County Commissioners. So we will let Commissioner Cuney, who is the past chair, possibly chair the Finance and Budget and Finance Committee instead.
Yes, I'm happy
Okay.
to chair budget and finance, which also usually the chair of the committees sit on the executive committee as well.
But
So
again,
I
does
will
get
not,
us,
as chair of the budget and finance committee and as past chair, since I am a commissioner, I will now not be sitting on the executive committee for those purposes.
All right, okay, we got through that part, so I will fill your name in on Budget and Finance Committee. I would ask, would Councilmember Cathcart be willing to chair the Policy and Education Committee and also serve on the Executive Committee?
I'm happy to do so.
Okay, so we are filling these up, that is good. Now I will look to everybody else on the board. Are there, is anybody, any committees jump out that you really wanted to serve on as far as Policy and Education, or Budget and Finance? I'll look to our new members. Commissioner Waldron, would you also like to serve on either Budget and Finance or Policy and Education?
Last year, I was on the Policy and Education, but it might be good for me to join the Budget and Finance just
Yep. Okay.
as vice chair.
Got it.
Probably to get up to speed for this next year's budget.
Okay, I will add your name there. We'll look to Patricia or Doctor?
I would. I'd like to be on the budget and finance.
You'd like Budget and Finance? Okay, we'll put you on there.
And I'm happy to serve on whichever committee.
Okay. Can I put you on Policy and Education? I think
Sounds
that might be
great.
a good
Fantastic.
one to have you on.
Yep, thank you.
Yes. Okay. And then I think we will put Charlie then on Policy and Education. All right, that went very quick and smooth. That is wonderful. I will just read through these just for the record, so it is clear. Budget and Finance Committee, we will have chaired by Commissioner Cuney. And then we will have Commissioner Waldriff and Patricia Keenholz. So that's our Budget and Finance Committee. Policy and Education Committee will be chaired by Councilmember Cathcart. And then we'll have Dr. Blakowski-May and Charlie Daranona. And then our Executive Committee will be myself, Commissioner Waldriff, and Councilmember Cathcart. All right. Can I get a motion to adopt these rosters as just stated?
So moved.
Okay.
Second?
All right, we have a motion and a second. Any further discussion? Seeing none, all in favor say aye.
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 Motion passes unanimously. I will hand that on down. Have that. Okay, that brings us to another action item, item number 6B. This is resolution number 24-02. This is authorizing the adoption of the revised procurement of goods and services policy. We did touch on this briefly last month, adjusting the dollar amount. So Kim is going to give us a presentation, just to refresh our memories.
Thank you. Good afternoon. This is the desire of the board from last month to bring forth our current procurement policy to lower the threshold for both the the administrative officer and Board of Health approval for $50,000 and up, and it drops it down from the $100,000 that it was previously listed. Otherwise, everything is the same with the procurement policy at this time.
Does anybody have any questions? Commissioner Cuney?
Yeah, and I think I was the one who brought this up because it was, again, just for public's awareness that we did raise that threshold during COVID because we needed to make sure that things needed to be timely and immediate and not be waiting for the board to have meetings to happen for that approval. And so that's why the threshold was raised from 50,000 to 100,000. And so we're just kind of bringing it back kind of to pre-COVID times. And it is similar to the Spokane County, our CE only has authority up to $50,000 as well. So it's just a pretty traditional within the government structure. So no reflection on anyone here at the health district. So I just want to make sure that this is just kind of an administrative issue. Thank you.
Exactly. Thank you. So just looking for approval of resolution 24-02.
Okay.
I move to approve Resolution 24-02.
Second?
All right, we have a motion and a second. Any further discussion? Seeing none, all in favor say aye.
Aye.
Aye. Motion passes unanimously. All right, that moves us on to our reports. Agenda item number 7. We'll start with our administrative officer. So, Dr. Thompson, take it away.
Hi. Thank you all. How do I advance the slides? They're not going forward the way they would normally go. What? Yeah. There we go. I'll use the mouse. Okay. So I wanted to give the board just a really high-level overview of what have I been doing for the almost past 3 months since I started. You have a more detailed outline in your packet, but I've really been focusing on getting to know SRHD and building rapport with our wonderful and amazing team. I developed a preliminary SWOT analysis, which again is strengths, weaknesses, opportunities, and threats. And I have established regular meetings, bi-weekly meetings with each of the executive leadership team members. I've met with 14 out of the 30 program managers, and I've held 8 meetings with Board of Health members and community members. And again, within your packet, right after the resolution, is the outline of everything that I've been doing. And then, what are my overall impressions? What an amazing team we have. That is my strongest, the team, and when I say team, I'm talking about all 200 and, waivers between 270, 280 employees. Our team is amazing, so dedicated, so committed to what we are doing here on behalf of our community's health. I have just been incredibly impressed. Our leadership team has amazing skills, and they complement each other. And the leadership team and the executive leadership teams, they work together to make us an even stronger organization. That is just wonderful to see and experience and be a part of. And then we do have some opportunities for increasing efficiency. I've pretty much outlined those in the SWOT analysis. And then I'm really looking forward to our next 3 months and beyond. So that is my report. Any questions?
Any questions? Nope. Thank you very much. All right, next up on our agenda is the financial report. Kim?
So in everyone's packet, your board member packet, you'll have the financial report for the month of January. So this is our first report for 2024. And for those new members, I'll be bringing forth each month a financial report of the prior month's financials. So I'm bringing forth January today. There's not a lot that happens in January. We spend a lot of time reconciling the prior year, 2023. So a lot of invoices that come in for January are expenses that we're paying for the prior year. Also, we do incur expenses first, and then the majority of our grants are reimbursement based. So the revenue that we will be receiving will be reflected in February's report rather than in January. So we incur those expenses in the month of January, and then we prepare the grant billing in February. And that's when the income will show up. So I just wanted to point out, this includes our 2024 budget, which does include, our original budget includes 281.9 FTEs when we prepared the budget last fall. And the total budget is $54,778,818. The report does have our expenses listed for the month of January, so we're at 7.8%. We'd expect that to be a pretty standard month, so 8%, we'd be right on track for 1/12 of our budget. So expenses are as expected. Our funding, though, if you look at that, we're down to 2.3%. And that is really a reflection just of the timing that we have not billed our January revenues. So I wanted to point that out. We do have a lot of federal indirect grants and state grants. And so January, you'll see just a small amount, $9,000 and $4,300 in state grants that we were able to bill before this report was prepared. Those will be significant next month, and you'll see that reflected. Medicare and Medicaid payments, we do billings each week, and so those are actually current for the month, so that's an actual month's revenue stream. And then our fees and our permits coming through with environmental public health, those are actual for the month of January. And there's some of the 2024 permits. The next categories we have for revenue would be the foundational public health services. You've probably heard a little bit about. We do receive funding every January and July. So that is one of the funding streams that's pushed out in advance. Actually, DOH was a little delayed in sending out the payment, so we didn't receive it till early February. Also, that payment is delayed from the legislature action back in November. So that first payment that comes the first part of the year actually is considered 2023's income and not 2024's. So what happens is we won't receive 50% of that allocation until July. And then in December, we'll also have an accrual for the second half payment. So you'll see that one sit idle for 6 months, and then we'll have a payment. Then the public health appropriations from the state of Washington, so 2877318, kind of rolls off the tongue because that's been a solid number for 20 plus years. It has not changed. And we receive that payment every January 31st and July 31st. So again, that EFT did not come in until first couple days of February. So that will be reflected next month. And then the county contribution, thank you, commissioners. We bill that quarterly, and so we have not, the transfer that happens between the funds just didn't happen in January. I imagine it happens in February. So that'll be reflected, and then you'll see a 25%, 50% there and going forward. Interest and earnings, that is just our interest that we earn on our balance of cash on our overnight investments through the Spokane County Investment Pool. So that does reflect an accurate 1 month interest. And then we just have some small donations that came in. We have some citizens that actually have payroll deduction coming in for our HIV STD program and our treatment services program. There may be other donations that will come in throughout the year. And then rents, we currently don't rent any portion of our building. However, we do collect parking fees from the employees for parking either at this location in our basement or the 8th Avenue location, are collected and retained by the health district. That helps offset some of our costs for the commute trip reduction program, some of those incentives. The expectation is that you will not make a profit on your parking revenue, but you'll cover the cost of the CTR, and you can cover your costs related to maintaining those parking lots. The parking outside of our building is actually owned by Spokane County, so we pass on, we collect the revenues and we pass that on to Spokane County. So we do not retain those dollars. Then the last categories on the budget for this year, we have assigned fund balance usage. So in the box in the lower section talks about the different types of reserves that we have. The first one is unassigned reserves, which is really our cash flow for our operating account. It's unrestricted. So we're sitting at 10 million here. So assigned fund balance usage, the next category, we have committed reserves, which would be the board emergency fund of 1.5 million. We cannot touch those funds unless we have board resolution that allows us to dip into those. So during COVID, when it initially occurred, we did ask the board for some access to those reserves, and then we were able to replenish them after funding streams started to come in for COVID. So we're back to the 1.5. Also, I should mention the unassigned reserves. We have a goal of 20% to maintain that for our healthy reserves for our operating costs. We've dipped to 18%, but then again, if you can see for January, we have a negative fund balance of $3 million, and that's just the timing of those payments. Once those come back in, we will be above the 20%. And then the third category of reserves is assigned reserves. So those are areas where at the end of the year, we'll determine if we have a fund balance increase or decrease, and then we'll work with Budget and Finance Committee, make some recommendations with the AO and myself on what are some of those projects that we need to set money aside. And so it's kind of management discretion to set those aside, and then as they're exhausted, then we would move them into the unassigned reserve so we could make those payments. So this outlines some of those categories. So going back up to the budget, the assigned fund balance usage, we have $753,698 that we're anticipating using out of the current assigned reserves. And then in the unassigned fund balance usage, the board did allow for to continue some of our epidemiology work that we were anticipating some grants to come in, and we didn't have confirmation at that time, but we didn't want to lose the expertise of our staff. So the board made the commitment that we could use 167,555 of unassigned if necessary for 2024's budget. And then the last category is carryover grant funds. So there are some grants, the health district financials and calendar year, our budget is on a calendar year, fiscal year, January through December. But we do have grants that are state, that go July through June, or federal that are October through September. So we do have carryover funds from those grants where they may have been unspent, and we can roll some of those dollars forward. So again, in 2024's budget, we're anticipating utilizing the $307,000. And then the last number at the bottom is our $15 million for our total reserve balance. And that is subject to change. We're closing out 2023's numbers now. We'll analyze and reconcile the assigned reserves. That'll be an adjustment, and I'll reflect that in the next report, what our reserves are for the end of 23. Any questions? Great, thank you. And I look forward to working with each of you on the Budget and Finance Committee. Thanks for your support.
Thank you, Kim. Next up, we have our Health Officer report. Dr. V.
Good afternoon, everyone. And with the chair's permission, I would just like to say welcome to nursing students that are here with us today. So members of the nursing program, thank you for coming. And following the Socratic method, I will be asking you questions. No, I'm just kidding. I probably won't. So I have to use the mouse, right?
No, it's not.
Oh, there you go. Wonderful. So today I have 3 subjects. I want to give you a little bit of an update on each one of them. The top one is not an update, but it's more of a conversation about a topic that has been in the news recently, and there's a lot of conversation in the community. And although it's not under our jurisdictional authority, it is an area in which we participate, and we participate particularly on education of the community. In your packets, you have a copy of this, which was just published by the County Medical Society as a review article for your reference. And for the students, you're supposed to read it, and then I will give you an exam at the end of today. They probably will never come back if I say that. Okay, this thing is not moving. There you go. Whew. Okay, so let's talk about PFAS, also known as forever chemicals. I'm sure most of you have heard about this by now. So going back in time, these are chemicals that have been around for a very, 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 very long time. Actually, it was a lab accident that generated the first one in 1938. A scientist had something in an ice bath overnight, and something happened where instead of a gas, they ended up with a powderish, whitish substance that generated the first of these compounds. I think the most important characteristic is the fact that they have fluorine as opposed to other chemicals, which was unknown at the time in organic chemistry. And trivia question for all of you, I'm going to ask you which one was the first one that was ever discovered? Polytetrafluoroethylene, which probably most of us know by the licensed trademark commercial name from 1941, also known as Teflon. This laboratory accident generated one of the strongest organic compounds ever made. These are all man-made, these don't occur in nature, and because of that strength, they have very unique characteristics. They're resistant to heat, oil, acid. They survive in environments in which other things don't survive, which is why we ended up with applications in pretty much every industry that we know of. And I'm going to keep doing this on the wrong side. Just to give you an idea, there's glucose on that side, which is the way most organic compounds are. This is one of them. On this side, where you see the fluorine substitutions that were accidental in nature, but as we started manufacturing this, became very intentional. Hopefully it's going to move the right way. Yay! This family right now, as the last count, is about 15,000 different compounds that have been generated since the 50s. And the reason why that is important is because as we started to apply this in pretty much most segments of the industry, from aerospace travel to toilet paper and everything in between, and I'll show you a picture, we started to realize that there could be some potentially toxic effects of the bioaccumulation or because of the bioaccumulative processes, meaning they accumulate in living organisms and they stay there for long periods of time. So if you look at this timetable, we figure out what they were right about here, then we started to deploy them pretty much everywhere. And many of the industries in which these were deployed, the use was quite intensive. For example, flame retardant surfaces. Like all of the firefighters' clothes were typically made with this type of material. And the flame retardant foam that has been used in firefighting for many, many years is made of this material because it really smothers the oxygen, so because there's no oxygen with it, the fire never comes back. But now we started to figure out that it was making its way into the groundwater, for example. So by the 90s, there were a number of studies in animal models that pointed to some potential toxicity, and the toxicity at that point in time was mainly in rat models with like kidney cancer, for example. By the 2000s around the world, we started to monitor its concentration in the environment. Actually, most countries, including the US, between 2000 and about 2019, did enact a number of legislative actions and laws to either prevent the use and or replace the use of this by other materials. For example, the EPA and the FDA have been testing foodstuff that is transported or imported in the country since 2019, because we knew that it was present in many of the canned products that came from other parts of the world. So this is a graphic depiction of the household applications that we had. And actually, Amy upstairs in communication put this slide together for me. But this is just to show you the significant uses that we've seen over the last 50 years. If you had Chinese food, if you had pizza, if you had takeout, if you floss your teeth, trust me, you were exposed. And why is that important? Because we do know that because of that bioaccumulation, there could be a potential health impact, and we'll talk about that in a second. But if you think about that, a lot of these things will end up in the trash. And because they end up in the trash, they may end up in a landfill. And because they end up in a landfill, they may actually end up in the groundwater, which is one of the ways that these are being ingested by drinking contaminated water. And as you know, that has been the focus of attention, not only in this community. I want to emphasize that this is a global issue, this is not just us. But I wanted to give you some background. So because of that, not only because of manufacturing, but also because of the use, the potential for that to end up in the soil, to end up in the water, and also once in the water, to evaporate and go further away, which explains how sometimes you find this contamination in places that are really, really far away from any potential contaminated site. And it's because of that atmospheric transport and the position that we see. So we started to figure out that these were available or were being found in a variety of environments. So I want to emphasize that this is not just here. This is something that we've seen everywhere in the world. And there are many countries like us that have enacted a lot of legislation and a lot of rules. Not every country has them. That's why the FDA and the EPA have been testing imports for many, many, many years. Now, this brings us to where are we at as of today. So we do know that there are 2,800 plus sites in which contamination has been determined. And you can tell that is some of it has to do with manufacturing, some of that to do with facilities in which flame retardant materials were being used or firefighting type materials were being used. So this is not unique to our community. We do know that in 2017 we did find some in the groundwater in the West Plains in the state of Washington, particularly in Spokane County, which then we joined this group of many communities that are dealing with this particular issue. Now, the good news is we know a lot about it now. We know how to filter the water, which is something that we probably didn't know before. But the question that usually comes up is, so what happened with all of that? Well, I can tell you between 1999 and 2000, there was a large, very large study by one of the government agencies that looked at blood specimens from, and you have to say to all of the acronyms, these were blood specimens of civilians, non-institutionalized people over the age of 12. That's the category. And what it boils down to, because of the concentrations, it was determined that 98% of the population had a detectable level at that point in time. Now, by then, industry has started to remove this product voluntarily, and we have started to use other products instead of the PFAS or the forever chemicals. So a study about a year and a half later demonstrated that geometrically, the levels were actually coming down. Now, what that tells us is pretty much most of us were exposed at some point, accidentally, by things we do. And the goal is to decrease the exposure so the ingestion is reduced. The goal is to bring this down to zero, and it will take a while, because one of the questions that people typically ask is how long will this thing stay in the body? Whether you're a human or a fish or a chicken or whatever, because they do go into other animals. And the half-life, meaning how long does it take to eliminate 50% of it, can be from hours to years, depending on which compound. And some of them are decades. Okay? Now, interestingly enough, although there's been a lot of conversation about water and vegetation and animals, the fact that it may be in the water does not mean that it will be in the vegetation or in the animals. It's not a direct 100% correlation. There are a lot of factors that have to do with concentration, the roots, the plant type, the type of animal, et cetera. And I could talk about it for 3 hours, but I won't. Example, shellfish accumulate more than fish, and fish accumulate more than other, and then marine mammals accumulate more than fish, and so on and so forth, which is why some diets are very high on it. But this is one of the questions that people ask, so how long is it going to go? It's going to stay around, and the answer is a very long time, and sometimes we don't know exactly. And I want to emphasize that we don't know exactly because there's a lot of studies being done. One of the questions that people typically ask is, what is going to be the impact on me, right? There's a lot of science, a lot of it still in evolution. At this point in time is, for example, the EPA will say can have potential carcinogenicity, but we don't have enough evidence to demonstrate that it does. The cases that we've seen have been associated with massive exposure, for example, industrial exposure, firefighters that wore this equipment for years at a time, etc. But we know that it can impact multiple organ systems, and in utero, it can be transferred from the mom. And children are particularly susceptible, which is not uncommon for children because of younger age and less physiologic evolution to have a higher susceptibility. There have been thousands and thousands and thousands of studies. So one of the things that was very important, the National Academy of Sciences, Medicine, and Engineering in 2022 did a massive review of the whole body of literature and tried to allocate a level of probability based on the science that we had. So what you have here in this table is things that we do know that there's a stronger correlation versus effects that We don't have enough science to say that's going to happen or not going to happen. We do know, for example, that it does can cause dearrangements on the cholesterol metabolism, dyslipidemias. Now, the issue is that cholesterol metabolism, dyslipidemia is a very common clinical disorder that can be due to a very, very, very long list of issues, but this is one in which the frequency of finding consistent with exposure was higher. The second one is smaller birth weight for infants whose mothers were exposed. We do know that we've seen more consistently in children that are immunized that were exposed and have measurable levels, the antibody response to immunization is lower. What does that mean? We don't know. But it's been determined. So the caveat there will be, if we know that, then we have to be very mindful with the immunization schedule of that child, make sure that it's very consistent. Now, the other one where there has been association based on like a lot of exposure is kidney and testicular cancer. And as I mentioned, this was in manufacturing and or firefighting for the most part. Last but not least, hypertension in pregnancy or preeclampsia, but we also know that eclampsia and preeclampsia can be caused by a long list of things. So, but these are the ones that have the highest level of association that we know. There are about almost 1,000 different clinical entities that have been identified with some nexus that we don't know exactly what that means. All right, so people say, what should I do? Well, a couple of things you can do. First of all, first question is, should I get my blood tested? In the state of Washington, there is a reference laboratory that does have a direct-to-consumer application. It's about $300+ or so. But there are other reference laboratories that clinical systems will have contracts with that can do it. The basic issue is that none of these laboratories do exactly the same way. Why is that? Because there are about 15,000 of them, so it depends which ones you're measuring. That's number one. Number two, as a snapshot in time. It tells you what you have right now, but it doesn't tell you what you may have had before or what you may have in the future. And very importantly, it doesn't tell you if you're going to develop any clinical condition. And I know that's kind of like a triple negative, because we typically think about diagnostic testing as confirmatory and or supportive. But in this particular case, all it tells you is where you're at right now. So based on that, there were some recommendations made by the National Academy of Sciences, Medicine, and Engineering, which were adopted and actually re-released on January 18th of this year by the CDC and other agencies in terms of if you have certain concentrations, there are some things you could do as a provider to manage your patient. For example, if you have higher levels, look for dyslipidemia if there's a risk factor. So make sure that as part of your annual testing, you do cholesterol panel and so on and so forth. If you have someone that is pregnant, pregnant women, make sure you're checking the blood pressure if there has been exposure, because we know about that. And because we do know that it's an endocrine disruptor, meaning it can disrupt some of the endocrine function, do standard thyroid function test if it's clinically indicated, particularly in either younger people and or pregnant women. And last but not least, in children that are over the age of 15, I just say children, in young adults over the age of 15, look for signs and symptoms of things like testicular cancer or also ulcerative colitis. But testicular cancer is one of those things that we look for in males from youth to middle age, just because of the frequency. If you go all the way to the bottom, lower levels pretty much provide standard of care, whatever the standard of care is for that person. So all of this has been distributed to providers. And one of the reasons why I bring this up is because, a lot of the questions that I got is, so what is my doctor going to do? And your doctor is always going to provide you the best care possible based on your circumstances and your risk factors. And this is just another risk factor that needs to be taken into consideration as they evaluate you. So with that, I'm going to move on from here to something that is also in everybody's mind, I think, I went to an event last night and everybody asked me about it, so I think it's in everybody's minds, which is measles. So measles is now gone. And actually, right now in the US, we've had, without counting the cases that we have, 35 cases in the first 2 months of the year. Last year, total year, we had 58. To give you some idea, England has an outbreak, and there are outbreaks in about 13 countries. As we all know, measles has been, for the most part, eradicated from most countries in which there's high immunization. It is still endemic in many parts of the world. Most of the cases that we see typically are associated with travel. And we, in Spokane County, actually do have confirmed travel-related cluster. Now it's 3 cases. I put this slide together 2 days ago and just got updated last night. We do have 3 cases in the same household. That close contact exposure with the index case, all of them susceptible, meaning not immunized. Now, we did release all of this detail. I'm not going to go through all of that, but we did release all this detail through the press and to our providers, just to make sure that anyone that was anywhere in those areas comes forward so we can determine what your risk level is. So what are the concerns that we have? Well, concern number one, when measles, after exposure, 10 to 14-day incubation period, when it starts being nonspecific. It just feels like anything else that you could potentially have. And we do know that before you get the rash, 4 days before, you are already infectious. 4 days after, you're already infectious. So that's a big, long period of time, 10 to 14-day incubation. And that's why, if you look at the previous slide, that person was going about their normal life, going to the places that people go, and could have potentially exposed a lot of other people in the community. So this is straight from our situation report. One of the things I want to point out is that the team has come together and put together a very nice and comprehensive not only report, but mechanism to respond proactively to any public health threat. And this will be the 3rd time we do this. We did it with mpox or monkeypox. We did it with Shigella and measles. And the numbers basically speak for themselves. We were able to control as much as possible, and our numbers were lowest for counties our size in monkeypox. Shigella, I'm going to show you in a second. Now, measles, the caveat is this is one of the most contagious pathogens for humans. So although we could have gotten way ahead of it with surveillance and et cetera, if there was exposure, then there may be the possibility for other cases. We had a very high level of index of suspicion for the household, and that has turned out to be true. We are still looking and exploring what other potential exposures may have occurred. These are some of the things that we did. And one of the goals of our strategy is to make sure that information is disseminated simultaneously to all that need it, and that includes our friends in the media who help us disseminate the information to the rest of us that may not have access to a provider alert or got the information through K through 12, et cetera. But this is information dissemination is one of the key components of this response, because the more we all know, the better off we are. The team took the opportunity to develop a fully automated tracking system, which we're very proud of. This is just one screenshot just to show you. And within that, we actually can develop a number of dashboards that help us track. And if you've been in private sector, I have been in companies, every CEO has on their computer screen 3 or 4 dashboards that give you a quick, where are we with today? So, and these are updated real time. So I want to do say that the folks up in DPR, Veronica, Lisa, Mark's team, they've done a really good job with this. And this is something that others can use for this type of issue. So with that, let's go to Shigella. We talked about Shigella, a couple of months ago when we first identified the cases. As you can tell, if you look at the tail of this, it's pretty much coming down. Again, I do believe this is because of that full court press that the team, the community partners, and all of those that we work with, from healthcare, shelters, et cetera, everybody went full court press on this, and I think the results basically speak for themselves. It's not over. Well, you still have cases. We're still on outbreak because the cases are still there. But as you can tell, they were initially very densely concentrated in our high-risk population, specifically our homeless population. But by now, a lot of that has been mitigated. Now we have cases in other community sources, as you will expect once things start to get under control in a particular high-risk environment. So for the nursing students, what that basically means is a really great job by the teams that were working on it. That's what it translates into. Just translation, okay? And then last but not least, the reminder that this is still a pretty serious disease, although we have seen hospitalizations become less frequent because those are the highest risks that has been contained. That makes sense? That's another exam question for all of you. So with that, I'm going to stop here and see if there are any questions for me. Yes, sir.
Councilmember Cathcart.
Yeah, just two questions. One, back on the PFAS. I'm wondering, the map you showed where they've identified it, it did not show Coeur d'Alene on there or Post Falls as being an area with PFAS. And I'm wondering, is that just because they haven't done the work to identify it, but it probably is as prevalent there as it is here?
That's a good question. And these are the confirmed, fully documented sites by the EPA. There's a list of other places under investigation, including around the Pacific Northwest.
Okay. And then on the measles, I'm wondering, I just want to verify, so the last chart you showed, does that indicate that those are folks that were unvaccinated but got measles? Or what were you trying to?
Yeah, no, this was when you have a highly contagious disease, you identify the index case, and then you identify everybody else around them that may have been exposed, and then there's high-risk exposure and low-risk exposure, and could be high-risk exposure unvaccinated, or could be high-risk exposure vaccinated. So what this was telling us is we looked at 30-something people and kind of put the risk stratification, and out of those 30-something, we have the index case plus 2 epi-related cases in the same household. The rest of the people we're tracking because of the incubation periods. We won't know the outcome of many of this until about next week, middle of next week, if you start to add the days.
But of the 2 cases that were confirmed, were both of them vaccinated or not?
No, they were not.
Okay.
They were the reason why I say they were susceptible is because none of them were vaccinated.
Got it.
Many of the other people were, although we do know that in that region, the immunization rate is a little bit lower than in other parts of the county. And Spokane County in general is a little bit lower than the state of Washington. So I'll use this to public service announcement. There is a vaccine clinic that is going on right now or later on today at Deer Park at 3? At 3 o'clock with our partners in K through the schools in Deer Park. I've opened to a community for both adults and children. So,
Thank you.
wonderful. Any other questions? Well, thank you. Appreciate it.
Thank you. All right, that next up brings us to our legislative update. Lola. Lola's been tracking a bunch of bills for us in Olympia.
Let's see. So good afternoon. I don't think we've had a big of audience before, so just to get a lot of you up to speed, this is a short session. 2, we won't be covering everything that's happening right now in the legislative sessions, simply because there's just not enough time. But the team here at the district gets together early in the fall, and we kind of talk about what our legislative asks are, and then we begin a process of putting together that documentation. So this presentation is really going to be following the process and actually getting us up to date on where we are in those specific legislative asks. So if you see that some of the information you might be interested in is missing, that's simply because this is the focus for the district. So hopefully that's helpful. So We know we just passed the opposite house fiscal committee cutoff, and we are coming very quickly up on the floor cutoff, and then we have the last session, or last day of regular session coming up on March 7th. So under our legislative ask for community well-being and resilience, we had House Bill 2157, where we were updating the definition of vaccine. That passed in the House on February 20th, and then it has been moved to House Rules X-Files. Some of this information is updated as of yesterday and this morning. This is moving very quickly, and so there might be newer information. I'll get that to you when I have it. House Bill 1608 was expanding access to the anaphylaxis medication in schools. That's been placed on second reading consent calendar as of February 27th. And then the House Bill 1899 is something that's kind of new to this list, but something we've been watching, which is facilitating the reconstruction of communities damaged by wildfires. That was passed to Rules Committee for a second reading on February 8th. More community well-being and resilience under our Senate Bill 6127. We're looking to increase the access to human immunodeficiency virus post-exposure prophylactics. This was moved to House third reading and passed on February 27th. Our vape detectors in schools was a House due pass and then referred to appropriations. And then under the Modernizing the Child Fatality Statute, this was moved to Rules Committee for second reading on February 24th. Under District and Community, 5983 was a bill proposed for allowing medical assistance with telehealth supervision to provide intramuscular injections for syphilis treatment. That passed the House on February 27th, excuse me. And then we also added establishing a pilot common public records portal. February 1st, there was the public hearing, and that moved to the Ways and Means Committee. Under our Nurse Family Partnership, Senate Bill 5580, improving maternal health outcomes, the Rules Committee relieved of further consideration, and the third reading was passed on February 28th, which I think was just yesterday. Is that correct? Okay. Wow, this month has gone so fast. And then we're monitoring still Senate Bill 5926, although we haven't seen a lot of movement since January 8th. Under Substance Abuse Prevention and Treatment, House Bill 1956, addressing fentanyl and other substance use prevention education, was placed on second reading, the consent calendar for the Senate on February 27th. And the Senate Bill 5906, implementing a statewide drug overdose prevention and education plan, was moved to the House for a majority due pass and referred to rules for second review on February 26th. Under Substance Abuse and Recovery still, Senate Bill 5804 concerning opioid overdose reversal medication has its third reading passed on February 27th. The state versus Blake relief by a resolution, it was reintroduced and retained in its present status, moved to House Rules X-File, and Senate Bill 5929, the fentanyl endangerment, had its first reading January 8th and referred to Law and Justice. I know that was really fast, but those were our focused bills. If there's any questions, I'd be happy to answer them if I'm able, and if I'm not, I'd be happy to look up information for you.
Any questions for Lola? Thank you very much.
Thank you.
All right, next on our agenda, that brings us to, we have some agency reports. So it looks like our first one is going to be a SRHD fatality reviews. And so we have Mia Morton and Mary Malone. Well, thank you for joining us, and you can take it away.
Hello, thank you so much for having us here today. I'm Mia Morton. I use she, her pronouns. I'm the Health District's Keeping Children Safe Coordinator.
And I'm Mary Malone. I use she, her pronouns, and I'm the district's Resilient Families Coordinator.
We're really grateful to be here today to have the opportunity to talk about SRHD's fatality reviews. Fatality reviews are a public health process that help us better understand and address preventable causes of death locally. We're planning for SRHD to conduct 2 fatality reviews beginning in 2024, child fatality review and adult overdose fatality review. At SRHD, both are funded by Foundational Public Health Services and recommended by RCW 70-05170 and RCW 70-05210. Many LHJs across the state are conducting or planning to conduct fatality reviews, including Benton Franklin and the Northeast Tri-County Health Districts. The fatality reviews that we're beginning are a central part of programs at SRHD. Child fatality review is a central component of the Keeping Children Safe program, which was established in December 2022 at SRHD to focus on preventing injury, violence, and mortality among infants, children, and adolescents in Spokane County.
The Resilient Families, the Adult Overdose Fatality Review is a central activity of the Resilient Families program, which was established in December 2022 at SRHD, but we didn't start looking at a fatality review until June of 2023. We're focused on families that are impacted by substance use through prevention, intervention, and treatment across the lifespan.
Now we want to give an overview of the fatality review process in public health. At a basic level, the fatality review process involves 3 steps: identification, review, and prevention. We identify cases by reviewing data from the Spokane County Medical Examiner's Office and the Washington State Department of Health. Our case definitions describe which deaths we review. For child fatality review, the case definition includes unexpected deaths of Spokane County residents that occurred after live birth before age 18 and were due to external non-natural causes. So this includes infant, child, and adolescent deaths due to suicide, homicide, sudden unexpected infant death, unintentional overdose, motor vehicle collisions, falls, fires, drowning, unintentional firearm-related injuries, and other means of injury. For child fatality review, we review all cases meeting our case definition.
For adult overdose fatality review, the case definition includes both accidental and intentional overdose deaths where the decedent is 18 years or older and resides in Spokane County. We review a selection of cases that meet our case definition, and the ME's office will help me to identify up to 12 cases per year that represent emergent trends. But for instance, right now, the rising rate of OD deaths in folks who are 60 years and older.
So after cases are identified, we move to the second part of the process, review. In child fatality review and adult overdose fatality review, cases are reviewed by a multidisciplinary panel of professionals during scheduled, closed, and confidential meetings. The panel includes law enforcement, medical, social service, and mental health professionals, as well as representatives from local cultural organizations. And the panel seeks to understand as much as possible about the life and death of each decedent, then focuses on identifying findings related to the risk factors, protective factors, and preventability of death for each case reviewed.
And then prevention is the final step in the process for child fatality review and adult overdose fatality review. The prevention process involves developing recommendations based on case findings and evidence-based practice, then formulating and carrying out action plans in the community to implement recommendations. We then share information with our partners and the general public through the media, fact sheets, and reports.
So that's a very quick overview of the fatality review process through these 3 steps: identification, review, and prevention. You also have a fact sheet with expanded information about child fatality review in your packet. We're wondering, are there any questions or comments?
Thank you very much. All right, next up, our next agency presentation, item number 7E2, the School Health and Safety Program Updates. We have Sandy Phillips.
Good afternoon, everybody.
Hello.
So Sandy Phillips, I'm the technical advisor in the School Health and Safety Program. And I'm going to be talking a little bit about our inspection program, just a super brief overview. Also a few of the current updates, and that includes the K-12 rule and then, or the WAC governing our program, and then the health and safety guide that's kind of a guidance document that's tied into the regulation. And then I'll also talk about the new lead in drinking water testing for schools. Yeah, so our current school inspection program started in the early 1990s. We cover and inspect all public schools that are in districts, all private schools, and all parochial schools. So basically what's excluded would be people that are homeschooling, only their own children at home. In this school year, which runs from the fall of 2023 to 24, we have 212 schools in our program, and that would include 134 primary schools and 78 secondary schools. Now, the regulations that we operate under for both inspections and also for construction, because we do plan review of all remodels and new construction for schools, would be the primary and secondary schools, Chapter 246366 WAC. That regulation actually came into effect in 1991. And so there was a new regulation, the 246366A, that came into, it was enacted in 2009. However, it's never been implemented. There's been a proviso on it, and every 2 years it comes up and it's reevaluated. It was related to somewhat to some testing, water testing for copper and things like that. Anyway, so it's been on the back burner, but this year, the state budget, 5950, has allotted or allocated for $750,000 to review that regulation, which could mean putting it into effect or opening it up again to kind of start over again. So, but the House budget actually doesn't have anything allotted, so we're not sure how that's going to work out, but there's definitely discussions going on and more to come, probably pretty soon, because that's August when that opens up again, so we'll find out in a few months. And then we also, under the regulation, there's a recommendation to have a health and safety guide that goes along with the regulation, because the regulation is fairly minimal. And so that was actually developed back in 2000, and then it was updated in 2003, but that's a long time ago. It hasn't been updated. There's a lot of references to regulations, particularly L&I regulations, which relate to school shops and science rooms. And so luckily DOH has been working on that. It started back before COVID, and it got put on the back burner like a lot of things. And so started up again last year, and we're looking at having the new updated version available in April this year. So we're pretty excited, and so are schools, about that, having good, correct references. So just move on to the lead testing in school drinking water. There was legislation passed in 2021 to require all public schools that had either been built before 2016 or had their plumbing replaced before 2016 to test all fixtures in the school for lead. I've seen a couple of reports, and it looks like for a public elementary school, that's probably about 50 fixtures, and for a middle school, about 80. Haven't seen a high school yet, but I think it might be even more because they're usually pretty much larger than a middle school. Anyways, this program is overseen mostly by the Department of Health, but there's also some OSPI involvement in it. So this requires testing either by DOH or a third party. So the schools cannot test themselves. Some schools have been proactive and had gone out and done some testing themselves, and unfortunately that doesn't count. So anyways, and based on the fact that if you hire a third party, the schools would have to pay for it, pretty much DOH is doing all the testing, which I think makes a lot of sense with budgets the way they are. Anyway, so this requires that all testing be done by June of 2026, and then they're going to have to test every 5 years after that. Now, DOH has some really good references, resources, guides, templates for schools. There's a handout on the back table there that's off their website. So if you're interested in it at all, there's a lot of good information on there and should be pretty helpful to schools that are going through the process, I think. So just to summarize what happens when, they do their testing, DOH sends a school back a report. We're getting copies of all those reports in Spokane County. Well, if the fixtures come back with less than 5 parts per billion in a faucet, then it's fine. They can just leave it in use. If it's higher than 5 parts per billion, then they're looking at doing some remediation and developing an action plan. If it's, and DOH recommends taking it out of service, but it's kind of a gray area there where they can just work on it. But if it's greater than 15 parts per billion, they have to shut it off that day they get the report. And then they can't bring it back into service until it's been remediated. There is a requirement for post-remediation sampling. We've heard from the Department of Health that some of the fixtures actually come back higher again, or high, and they think it's probably because of disturbing the plumbing and things like that, so it seems like it takes a while to flush out the system. Anyways, they are required to communicate with parents, staff, and the public, let them know, what the results are if they get the high results, let them know what their action plan is and what, their plan going forward, and answer any questions. But the good news is that OSPI does have some grants available to help schools with the remediation because it could be quite expensive. So, and just anecdotally, some of the reports I've seen, I saw one school that had 3 high faucets out of maybe 50 that they probably would have had to shut down, and then, a few in the sort of middle category. So fortunately, haven't seen any with a whole lot of fixtures that they would have to change. So anyways, I will pass to Jeff in our liquid waste program. He's going to give an update on some new regulations.
Hi, so I'm Jeff Harris, the technical advisor for the liquid waste program up in EPH. So just briefly talk about the code revision to the on-site code, which is the WAC 246272A. The revision process started back in 2017. Again, obviously with delays in COVID. It was finally adopted by the State Board of Health in January of this year. The major components that really affect our program in Spokane are licensing of O&M providers and then the property transfer inspections that will be required. The code is not effective until January of 2025, and then the property transfers for counties that do not currently have that program in place is not until January of 2027. Again, Spokane, we are not one of those counties that currently have a property transfer program. So the hope, again, is to have some type of O&M program or licensing by January of 2025, and then something in place in relation to the O&M operation maintenance for the property transfers. We don't know exactly what that will look like yet. We're actually still waiting for the final draft of the code from the state, which they have not given to, or it hasn't come out yet. So as far as specifics, we're not sure, but it's something we're obviously going to be working on through the next year. And then we have a couple years to get the property transfer inspections, that program figured out. So Any questions for Sandy or I?
Any questions? Commissioner Cuny?
Yeah, so with the liquid waste program, okay, so currently, it's just ensuring that the septic system meets the requirements as someone builds a home. And so now, upon transfer, if a person sells that home, then there's going to be this new inspection. And so do we anticipate that we'll be doing the inspection, or it'll be independent contractors do the inspection, and we'll look to see that we have that?
The latter. So we don't have the resources. There's only 3 of us inspectors. So I think it was mentioned up to 1,500 transactions. Granted, that's all transaction, not just properties that have on-sites. But yeah, it's likely a third party, the O&M providers, we're looking at licensing those, and then they will do likely the inspections, the property transfer inspections. And then part of the code, again, we don't have the final draft, but we'll have some type of reporting form for them to use to submit to us for a review at that time of sale.
Okay. And we have a couple years to figure this
We
all
have some
out and
time
get
to play
this
with it. And
all in
the
place.
west side of the state, actually, almost all the counties have something in place as far as property transfers. So we're reaching out to them to kind of figure out how they're doing it as well.
Okay, thank you.
I had a question for Sandy. Sandy, when you're looking at the lead levels at the schools, we have some schools that are very, very old. I mean, honestly, historic buildings. How do you know it's the fixture and not sort of more up the line in the plumbing of the actual school?
That's a good question, and it can be really hard to figure out. I noticed on one report we saw, being somewhat familiar with that school, I think it was maybe one wing, like towards the end of the school. So it could be that some of those fixtures don't get a lot of use. Yeah, again, there's some pretty old schools too. I would say the good thing is there have been a lot of school replacements that have taken place, particularly in the city. So new construction is always good, replace those fixtures. But yeah, I think they might have to they'd obviously have to look at the layout of the school and figure out, because it might not be the fixture, it could be further up in the plumbing or even connection to the school. So yeah, not simple to determine all the time. So yeah, the facility maintenance people have their work cut out for them, I think.
Okay, and you had a reference to anything prior to 2016 needed testing. Was there some sort of change in manufacturing standards in why 2016 was a certain date that was on the slide?
Yeah, the 2016, I'm not exactly sure how they came up with that.
Okay.
Probably the manufacturing no longer using, the lead in the fixtures. I would assume that was the case.
Okay.
And as far as testing previously, some schools have been proactive because there was in that 246-366A that I mentioned, the rule that was enacted but not implemented. They actually covered testing in drinking water, and so there were quite a few districts who were very proactive. They jumped on it, they started doing it, but the protocol was different that they followed. So they only did a percentage of fixtures, and then some of them did it in the summer. This requires doing it during the school season. So unfortunately, they spent that time and did that work, which is good information to have, but they still are going to have to have it all redone. So,
okay.
Yeah.
All right, thank you.
Sure.
Any other questions? Okay, well, thank you very much. All right. Next up, we have, and then that, we are, okay, and Jeff just gave his, so. Okay, that will move us on to board member check-in. So we'll work our way around. Councilmember Cathcart, anything for the good of the order?
Nothing for me.
Okay. Patricia?
I'm happy to be here.
Okay. Commissioner Cuny?
I'm good as well, thank you.
All right. Dr. Blakowski-May?
Yes, thank you very much. It's been very enjoyable. I just wanted to voice my appreciation for the orientation that we had today. I thought that was a great welcome. So thank you all and all the staff for helping me out with that today.
Dr. V, anything for the good of the order?
No, thank you. Just welcome to our new board members and our WSU students. And I'll ask you questions when we're done.
All right. Dr. Thompson? All right, Commissioner Waldron?
I just wanted to say I thought that the media work done on the measles case was well done. Right away, I appreciated getting an email from Dr. Thompson, and then that night in the media, it was like the top story, and people knew, and you had real locations so people could understand if they potentially could have been exposed. So I just thought that, just want to give kudos to everyone who worked on that, because I thought the information got out very quickly, and it was, hopefully the media mostly got it right. I think that they did.
All right. And yes, I just want to say welcome aboard to our new members, and thank you to all the staff who presented today. It's excellent information. That will bring us to adjournment, and it is 1:48. Everybody have a great afternoon.